Welcome back to the third part of New Directions and Approaches in the Management of Patients with HER2-Altered non-small cell lung cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Joshua Sabari from the NYU Langone Health Perlmutter Cancer Center in New York City to discuss key presentations and publications in one of the most exciting new areas of oncology research, particularly the recent approvals of two HER2-directed tyrosine kinase inhibitors, zongertinib and cevabertinib. Dr. Sabari continues his discussion of key presentation and publications, focusing on an article from the Journal of Thoracic Oncology on the continuing evolution of trastuzumab deruxtecan in non-small cell lung cancer, specifically the DESTINY-Lung-02 trial, a randomized, dose-blinded, multi-centered phase 2 trial in HER2 mutant disease.
T-DXd is a very effective therapy. Remember, it's trastuzumab deruxtecan. It's a HER2-directed antibody-drug conjugate. Most of you listening have a lot of experience with this agent in breast cancer, for example, and gastric cancer, and that's mostly in the HER2 overexpressed patient population. Remember, here in lung cancer, we're specifically looking at HER2 mutation by NGS. So a HER2 mutation, the DESTINY-Lung-02 study showed very impressive response data. Remember, in this study, we looked at two dose levels, 5.4 mg per kg, which is the approved dose, as well as 6.4 mg per kg. Interestingly, the response rate was higher for 5.4 mg per kg at 51% versus 6.4 mg per kg at 28%. How could that be? Well, toxicity, right? We saw much higher rates of ILD, twofold in the higher dose level than we did in the 5.4 mg per kg. And when we look at progression-free survival, it was in that 9 to 10 month range for the 5.4 mg per kg and about 15 months, interestingly, for that higher dose. But again, we wouldn't recommend giving the higher dose level given the high rates of toxicity. One thing I think is important, and you mentioned this, the patient-reported outcomes. This was presented by Dr. Jänne PA. Patients did tolerate the therapy well. What do patients want, Neil? They want to live and they want to have good quality of life. They want to do the things they love with their family. So, having cancer is a bad thing, right? And we need to try to get it under control. Patients are willing to take on minimal toxicity to have that benefit. Now, if there are other therapies that are available that are better tolerated, it's our job to give patients the best therapy with the best quality of life. So for me, trastuzumab deruxtecan is still relevant in this setting. Remember, we're not curing patients with tyrosine kinase inhibitors. Everybody essentially will develop resistance over time. Having trastuzumab deruxtecan as a later line setting is extremely important as an option for our patients.
We had a case, presented a 5-year response to T-DXd. We had another case where the patient progressed in a few months. I'm not even sure I've seen this in breast cancer in terms of predictors of benefit with T-DXd. Are you aware of anything?
Yeah, we don't really have great biomarker studies here, and it's an important point. For mutation, we've started to look at, sort of resistance mechanisms, and interestingly, it has nothing to do with HER2 expression or HER2 mutation or change in the HER2 mutation. It actually has to do with chemotherapy and sensitivity, efflux pumps, for example, and other mechanisms. So it's more payload resistance as opposed to mutation resistance. And look, more studies need to be done in this population to better understand this. We've also, Neil, not really ever seen data on sort of different response rates between mutation, amplification, and overexpression. We know these are different entities. We know that they can co-occur. What we have seen in large databases is these numbers pulled out. So, IHC 3+, we know the response rates are pretty good for trastuzumab deruxtecan, and there's an approval there. But what if a patient is HER2 mutant and overexpressed, or HER2 mutant and amplified? We don't really know what to do with those patients in 2026. So a lot of work right now is ongoing to try to better elucidate biomarkers for specific therapies. Neil, that might be a patient in the future that we want to combine modalities with if they have potential bypass track mechanisms.
So you mentioned quality of life with T-DXd. One thing I always find interesting is, and a big determinant of quality of life, I think, is some of the acute GI toxicities that you can see with T-DXd, sort of chemo-like side effects. And I find it really interesting that, that when you talk to the breast cancer people, they're extremely aggressive about preventive antiemetics. They give the patient olanzapine, they give triple therapy. But yet when I get outside all the other areas that are now starting to get used to T-DXd, I'm not sure I'm hearing the same message. I don't know whether the patients are different or clinical experience different, but what's your experience, again, with T-DXd and these acute GI toxicities, and what kind of preventive strategy do you use?
Yeah, you make a really important point. I was talking to a group of community oncologists the other day, and this group had far more experience than I do with ADCs across other diseases than I do in lung cancer. So I agree with that. I think that if you're using these agents day to day in your practice, you need to use prophylaxis. You need to use antiemetics, as you mentioned. You need to educate patients on the side effect profile. One side effect that we see with some of these agents is stomatitis, not something we commonly talk about, right? But in the community, docs are treating this day in and day out. We're trying to integrate this now into our practices. We also see interstitial lung disease, right? This is something that needs to be managed aggressively in this population. So Neil, it's a great point. In the HER2 space, we have not been talking about how to manage and mitigate side effects with HER2-DXd, the TROP2, or not TROP2, excuse me, Trastuzumab deruxtecan. So we do need to better educate our patients and think about strategies of preventing some of these adverse events. Because Neil, we know if patients can't tolerate a therapy or can't be on therapy, they don't derive the clinical benefit from that treatment.
So another thing that's interesting is when you, again, talking to breast versus outside of breast, is the breast people are very, very aggressive about trying to pick up ILD. They do scans in asymptomatic people as often as they can get them, like every 8 or 12 weeks. And the other thing is they're trying to pick it up when it's grade 1, asymptomatic. If it is grade 1 and then they treat and they recover, they'll retreat. But if it's grade 2, if they have any symptoms in breast, they will not retreat. Again, I'm not sure I hear all the same things outside of breast, but what's your approach in terms of preemptive imaging? Of course, you're imaging them anyhow, very often because of other reasons. And also, will you retreat either grade 1 or 2?
It's interesting if you look at a 40 to 60-year-old woman with breast cancer versus a 65 to 75-year-old patient with lung cancer, different comorbidities, different, issues. COPD, quite common, right, in lung cancer patients. Prior radiation to the chest, more common, right? Prior immunotherapy, more common in our lung cancer patients. So I agree, it's very tricky to read these scans. But I think that if a patient has a grade 1 pneumonitis, remember, that is radiographic pneumonitis, no clinical symptoms. I do hold therapy with Trastuzumab deruxtecan. Why? Because I've been burned before where we continue treatment, patient then develops symptoms over time. I think if you can hold therapy, let that pneumonitis resolve radiographically, you can then resume therapy safely. Once patients have symptoms, shortness of breath, hypoxia, grade 2, or even grade 3, right, full-blown, pneumonitis, I do not retrial the patient in my clinical practice. Again, pneumonitis is very hard to treat, and we need to give prolonged steroid courses. I'm talking about, 1 to 2 milligrams per kilogram of prednisone for weeks, not a quick week, taper. So I tend to be very, very, sort of cautious with pushing the envelope if a patient has grade 2 or grade 3 pneumonitis.
So let's move on to our next topic, and we have a little bit of kind of our research to practice office pool when we do webinars about how long it's going to take when we do a webinar on a solid tumor before somebody in the chat room goes, what about ctDNA? But at the same time at ESMO that they were presenting this phase 1A study, I think in first-line therapy that got it approved, they presented some really interesting data on cell-free DNA. So can you talk a little bit about what they looked at and saw there? This is another one with John Heymach.
Yeah, so, circulating tumor DNA has become, sort of very important in our clinical practices, particularly in stage 4 patients. We want to identify the mutation in the blood. If we don't identify it in the blood, obviously we fall back on the tissue, but if it's there, we can act upon it. So one of the questions that we asked on this study, especially in the phase 1, was, what are the dynamics of that clone of the HER2 mutation? And what we saw was quite impressive, dramatic reductions in this variant variant allele frequency, the percentage of tumor DNA identified in the blood once we started zongertinib. What's also very interesting is if a patient is progressing, you can actually see in real time the allele frequency rise of this mutation. Now, what do we do with this in clinical practice in 2026? Not much, to be honest with you. It's really helping us better understand resistance mechanisms. I have a couple of patients in my practice who ask for ctDNA. I think it only adds headache. It adds anxiety. They get stressed out, and the false negative rates are still quite high in my clinical practice setting. But in those patients who had ctDNA detected at baseline versus those who did not, those who had ctDNA detected at baseline tended to do worse than those who didn't. And we've seen that in the EGFR space and the ALK space. It correlates with, amount or burden of disease. So I think ctDNA is just a surrogate for us for amount of disease. It's a really nifty tool for us to study and understand resistance. But this presentation sort of correlated what we've seen in many other driver mutation patient populations.
And of course, I know in the localized setting, adjuvant trials, et cetera, we saw data with ctDNA with osimertinib. I imagine we're going to start seeing that as well. It's funny how my brain sort of flips into other tumor experiences. Last night, we had a webinar on prostate cancer, which nowadays you can't even get through in an hour. There's so much stuff going on there. But one of the things we talked about is their increasing use of intermittent therapy, endocrine therapy, when patients who have great responses, looking at PSA. They don't use cell-free DNA, but they look at PSA. And I wonder, like when you look at particularly some of these, I don't know, do you actually see the allele frequency go down to zero? And can you envision, I guess these people are going to be treated indefinitely. I'm not sure what about they're going to do in the trials, but do you think we could ever get to a situation where maybe we would be looking at this to decide how long to treat patients? Maybe if they are, quote, MRD negative, give them a treatment holiday, or where do you see this heading?
Yeah, it's an important question. I think we could learn a lot from prostate cancer or even CML, right? With, the earlier, targeted
absolutely.
therapies like imatinib. But in the HER2 space, we do see patients clear their ctDNA. I would not stop therapy because we know that if we stop, we're going to see, clones again arise. But what is interesting, and we don't have data for this in the HER2 space, but we have a lot of data in the EGFR space. If you clear your ctDNA, usually at, 4 weeks to 9 weeks post-initiation of therapy, those patients do far better than in a patient who doesn't clear their ctDNA, meaning you start therapy and you repeat ctDNA 4 weeks to 9 weeks out and you still see a clone there. Maybe those are patients that we should escalate therapy. But the idea of discontinuing, I don't think we get to complete molecular response with our current level of therapies. But, hopefully in the future we will. And, maybe we can use ctDNA to better help us decide who to de-escalate therapy in, Neil, who to escalate therapy in, and maybe who we can stop therapy in the future. But we're not there yet in 2026.
So I want to ask you about this paper. I always love trials in progress papers and posters so we can see what's going on, but also a lot about what they're thinking about. And this is really what I also like Future Oncology, very different type of journal, very educational. They do a lot of these. But PanTumor-1 sounds a little familiar. Kind of reminds me of T-DXd's pathway. It looks like they're trying to do something similar. And again, when I had this wild conversation with John Heymach last summer, he was saying you can see these TKD mutations in other cancers. I've had a couple of cases presented to me where nobody even thought about it, but I saw it on the workup, So any comments on this paper, on this trial that they're doing, and what do you think it might show?
Yes, this is a study being led by Allison Schram. We trained together. We're co-fellows together. She's at Memorial Sloan Kettering in the phase 1 group. And this is the pan-tumor analysis of zongertinib. And I agree with you, Neil, this is similar to what we saw with trastuzumab deruxtecan. Here, we've been talking today a lot about HER2 mutation. This study actually is asking a different question. This study is asking about HER2 overexpression, remember, by immunohistochemistry, or HER2 amplification, increased copy number by NGS or by FISH. And this is tumor. I mean, any histology can enroll onto this, study. And it's an important question because we've been asking this from the get-go. this drug works very well in HER2 mutation lung cancer, but what about amplification? What about overexpression? And what about other histologies? And I agree with you. Once a week I get an email from a colleague, out in the community saying, "Hey, I have this gastric cancer with this mutation, or I have this, endometrial cancer with this mutation, or this overexpression. Can I use drug X or drug Y?" And I think we need to do the studies to better understand that. So for right now, we don't have data for zongertinib or cevabertinib in the amplified or overexpressed patient population. Really, the data we have for this group is for the trastuzumab deruxtecan, the HER2 ADC. So very much looking forward to seeing the study enroll and to seeing the data. Hopefully it changes practice for our patients.
Well, just a point of clarification. It looks to me like they are looking at HER2 mutant in addition to overexpressed.
I think there is a cohort on this study where they can look at HER2 mutant, but we actually have data in the phase 1 already in the HER2 mutation positive patients. And honestly, the drug is active there. That I don't think we need to wait for this data. If a patient has another solid tumor that has a HER2 mutation like the YVMA, which is rare, zongertinib will be active. How active and large data sets, we don't have that yet, but we are looking at a cohort of those patients as well in the pan-tumor study.
So are you saying that there are cases reported outside of lung cancer with this mutation who responded to zongertinib?
Yes. So there are cases of patients with activating mutations, tyrosine kinase domain mutations like the, YVMA, but there are others, right? I mean, there's a 777L mutation that we more commonly see in breast cancer, but now I'm starting to pick up in lung cancer, and we've also seen it in gastric cancer. Also highly responsive to zongertinib. So this is a story out of the, driver mutation space. It doesn't necessarily matter what histology you have. If you have that mutation, the drug may be effective. Again, the FDA is going to want to see data in those subsets of patients, and that's why these studies are ongoing.
So if I could just interject a question I meant to ask you in the beginning, because I'm probably the only one who's confused about this, but so I understand that these TKD mutations are exon 20 HER2 mutations, but we also have exon 20 EGFR, insertion mutations that we use amivantamab plus chemo for, right?
That's right.
So that's a completely different mutation, but in the same exon.
Yeah, Neil, you're not the only one asking this question. I get this question twice a week, mostly from my patients, but also other clinicians, right? So, we talk a lot about HER2 exon 20, but we also talk a lot about EGFR exon 20. Are these the same mutation? And the answer is no, but they're cousins of each other. They're homologous, meaning that, the actual structure, the location of the mutation looks relatively similar. For HER2 exon 20, it's the YVMA insertion mutation. For EGFR exon 20, there are over 200 different exon 20 insertions that have been developed. What's even more confusing, Neil, is a lot of our therapies, a lot of our oral therapies, for example, cevabertinib, which has HER2 activity and EGFR activity, have been studied in both EGFR exon 20 as well as HER2 exon 20. So it is really confusing in clinical practice. It's important to clarify, though, that zongertinib is a HER2 selective inhibitor and does not have any EGFR exon 20 activity. So I think of these mutations much differently in my practice, but they are cousins of each other.
So I want to talk a little bit about some of the ongoing trials, but also just wanted to bring up, you mentioned gastroesophageal cancer. We just had the ASCO GI meeting, and I'm curious if you know anything about this in lung cancer. I've been asking the breast cancer people. They have a bispecific, zanidatamab, that hits two parts of HER2 and is approved in biliary cancer. And now at the GI meeting, we saw a wild first-line trial, and looks like it's going to be first-line therapy. What about this bispecific in lung cancer? Do you know anything about it?
Zanidatamab, it's a HER2 bispecific antibody. I think it's a really exciting compound. You mentioned approval in cholangiocarcinoma. You better be sure we're studying this in lung cancer as well. I think this could be an interesting opportunity for us to combine with other tyrosine kinase domain mutations. So studies are ongoing at this time. Remember, every drug has a phase 1 study where we're pan-tumor. So we do have early data for zanidatamab in the HER2 mutant lung cancer patient population, but we need to grow that. We need to better understand this in this setting. So I think this is exciting that we're now seeing rush of targeted therapies entering the HER2 space. Prior to zongertinib, really trastuzumab deruxtecan, this was a population that we thought we couldn't effectively drug, but that has now changed in the last few years.
So when you were talking about, we were kind of thinking about moving things up as they always do. I'm curious whether we're going to, I know there are trials looking at the adjuvant setting, but a really important area that I think pops in mind immediately is sort of the locally advanced non-surgically resectable durvalumab type cases where, we started moving with targeted therapy away from durvalumab and towards osimertinib and ALK agents and maybe even more. Any comments on zongertinib in that situation?
So, it's interesting that when you think about, sort of the phase, sort of stage 3 patient population, stage 3 patients who are, getting concurrent chemo-RT have a, 50% plus chance of recurrence, maybe even higher, 75% chance. We know when we added durvalumab, it reduces the rate of recurrence. So remember on the Pacific trial, 43% 5-year OS rate. But what does that mean for our driver mutation patients? We saw the data for EGFR on the LAURA trial where we dramatically improve, or we reduce the risk of recurrence and dramatically improve overall survival when we use osimertinib in the adjuvant setting. There are studies ongoing right now with zongertinib in the HER2 setting. So we'll have to see what that data looks like. I'll be honest with you, if I have a patient in my clinic tomorrow, I'm going to use off-label zongertinib in the consolidation setting post-chemo RT. I'm not going to subject patients to durvalumab. We know that durvalumab is not as successful in that patient population. There are also adjuvant studies. I think it's the Beamion LUNG-2 that are ongoing in the adjuvant setting population. And Neil, you mentioned earlier neoadjuvant, right? We've had a lot of data accumulate in the EGFR space. I think, the earlier we give these therapies, I think the more effective they can be in our patient population. It gives us multiple shots on goal. So there are studies ongoing in this space as well.
Yeah, it's really interesting when you see a new target, a new type of treatment, they take advantage of everything we've learned about targeted treatment, and you're getting answers so much faster than, it took forever to even get a phase 3 trial with osimertinib going, and now we're out adjuvant, neoadjuvant. It looks like, as always, a similar trial with cevabertinib as well in the same setting.
So, for cevabertinib and zongertinib, as well as trastuzumab deruxtecan, all of these drugs are being studied now in the frontline setting, right? So Beamion LUNG-2 frontline, SOHO-2 frontline, and I think it's Destiny LUNG-4 in the frontline. Remember, that's comparing to chemotherapy and immunotherapy. The question is, can you move these agents earlier on into the adjuvant and neoadjuvant space? A lot of that is going to be dependent on the tolerability of the agent, right? It's hard to think about giving trastuzumab deruxtecan in the consolidation setting for a year, let's say, but maybe the study should be done so we better understand that. TKI really are amenable to that sort of consolidation or adjuvant scenario where patients can be on therapy for 3 years, for 5 years, because they're well tolerated and they don't significantly affect quality of life in this patient population.
So continuing on this theme of ongoing phase 3 studies, very interesting. Destiny LUNG-4, first-line treatment with T-DXd with locally advanced or unresectable or metastatic disease, HER2 exon 19 and 20 mutations eligible for this study. Any thoughts about this trial, and what's a HER2 exon 19 mutation?
Yeah, great question. This is the confirmatory study, Destiny LUNG-4 for trastuzumab deruxtecan. Remember, trastuzumab deruxtecan has an accelerated approval in the second-line setting. This study was initially set to enroll 264 patients. I think we've doubled that now to over 400, and it's completed accrual. We're waiting, bated breath to see the results of this. Is T-DXd, is trastuzumab deruxtecan better than chemotherapy plus immunotherapy in the frontline setting? Here in this study, we're not only enrolling, HER2 exon 20, we're We're also enrolling HER2 exon 19 mutations, which are quite rare, but again, they're still in the tyrosine kinase domain. So this is similar to what we're seeing in the other trials, like the SOHO-2 with just cevabertinib versus chemo IO, as well as the Beamion LUNG-2, which is zongertinib versus chemo IO. I think, in the next, year or so, Neil, we're going to see 3 phase 3 studies read out, and it's going to be a huge amount of information to process and to think about, but it'll help us better select patients for these trials. I'm hoping all 3 are positive for our patients.
So the final paper I want to ask you about is an interesting one from Dr. Jänne et al. Again, looking at T-DXd and HER2 mutant non-small cell lung cancer with or without brain mets. And I guess they sort of pooled a bunch of randomized clinical trial to come up with this. What was the bottom line of what they saw, including what they saw in the brain?
So brain metastasis, Neil, 30 to 40% of our patients. It's quite common. We know that patients develop CNS mets over time. With trastuzumab deruxtecan, we did see good responses in the brain, over 40% response rate. Some of the responses were quite deep. We also saw the response rate look a little bit better, or duration of response for the higher dose levels than the lower dose levels. And, again, this is a therapy, trastuzumab deruxtecan, that shouldn't get into the brain, right? It's a large molecule. It's an antibody drug conjugate, but consistently across different studies, we're seeing CNS activity. I think we need to get our CNS activity at the same rate that we're seeing extracranial activity. And we talk a lot about this in academic centers as KPUU, meaning we want the activity of the drug in the blood to be the same as the activity in the brain. We're not there yet. We're still at about 0.5 or 0.4 for a lot of these agents. It's got to be 1. So we're starting to get there in some of these tyrosine kinase inhibitors, but I think we need to do more for patients with active CNS metastases. And there are many new HER2-directed therapies that are specifically built to target CNS metastases.
So again, I'm always thinking, I think probably general medical oncologists also can't help but thinking about what they're hearing in other cancers. And it was a really cool story that evolved in breast cancer in terms of brain mets. That they had a TKI tucatinib, which I want to ask you about, HER2 TKI, and it seemed to be effective in brain mets, and it became standard of care, I think second-line therapy with brain mets. And then along came T-DXd, and although it wasn't compared to tucatinib indirectly, it looked better in the brain. Everybody was like, wow, we didn't know that ADCs got into the brain. And now T-DXd is usually given before tucatinib. But it also brings up the question of other TKIs. We have neratinib out there, it has a long history in breast, and I think a little bit in lung. But what about some of these other TKIs? Do they also target this TKD mutation?
Yeah, so, tucatinib is a known CNS penetrant agent. You mentioned neratinib, there's pyrotinib. From John Heymach's group, there's an older agent called poziotinib. I think the problem with a lot of these agents, is that they had significant toxicity, right? Mostly, HER2 EGFR-mediated GI, diarrhea, as well as skin cutaneous side effects. So I agree with you in the breast space, and I don't even pretend to be a breast oncologist, in real life. But when we saw the data for trastuzumab deruxtecan, having superior CNS activity, that replaced the TKI. And I think that, it's important for us that we shouldn't think about mechanism, targeted therapy or an ADC or chemo. Use the drug that is the best for your patient in that setting. But for me, where I think this could go is we can see combination strategies here, Neil, especially for patients with CNS metastases. I'd love to see more CNS penetrant tyrosine kinase inhibitors, potentially in combination with novel mechanisms of targeting HER2. So really an exciting time, an exciting space for patients with HER2 mutations and for us as oncologists taking care of these patients. We're far from the days of chemotherapy, right? You mentioned the IPAS study. We now have multiple HER2 targeted therapies. That's pretty cool. Even when I trained, we didn't have that.
So, yeah, actually, when you were talking about the diarrhea with cevabertinib, I was actually flashing on neratinib because there was a study in the post-adjuvant setting where an triple positive patient, they saw a really great benefit, and then people did not want to use it because there was such a problem with diarrhea. Then they kind of figured out what to do, and now it's a lot more tolerable. But what is the direct mechanism of why you see diarrhea or colitis with these TKIs? Is it a direct effect on the bowel?
It is. I think it's inhibiting the wild type. So EGFR and HER2 wild type, I think, gives us this diarrhea. We know that both EGFR and HER2 are expressed in the skin as well as the GI tract, the bowel. And, we can dial out some of that wild type inhibition with some novel, sort of medicinal chemistry type mechanisms. And then we can make drugs, spare certain, mutations or certain, genes, like, zongertinib totally spares EGFR. So there's no EGFR wild type inhibition. And, I've been burned before developing some of these agents. Yeah, some of these drugs have very significant GI tox. And again, if there's a patient sitting in front of you that has no other option, they're willing to take on that GI tox. We're willing as clinicians to take on that toxicity and manage it with patients. But if you have better agents available that are less toxic, I think it behooves us to use those agents for our patients in the clinical practice setting.
This concludes our program and our series. Special thanks to Dr. Sabari, and thank you for tuning in. This is Dr. Neil Love for New Directions and Approaches in the Management of Patients with HER2-Altered non-small cell lung cancer.